Stellenbosch University is a leading research-intensive university on the African continent, and the Faculty of Medicine and Health Sciences of this university contributes significantly to the world-class research output of this institution. Our research addresses some of the toughest health challenges on our continent, in our nation, and in the world. The annual academic day is a highlight of our academic calendar, and it showcases and celebrates our faculty's ongoing world-class research. It also provides an opportunity for us to acknowledge the commitment of our researchers and support staff, whose efforts are indispensable in the success of our research enterprise in this faculty. We hope that the annual academic day of 2014 will be a showcase of our research, and that it will become evident through this day how our researchers contribute to our faculty's vision, which is to advance health and equality to South Africa and beyond.
In South Africa, we've got a particular problem with cervical cancer, which is the second most common cancer in women in South Africa, and we know it's the most important cause of death of women due to cancer in South Africa. It's estimated that about 1 in 30 South African women will develop cervical cancer during their lifetime. As such, we know now that cervical cancer is caused by human papillomavirus, which is a very common virus infection. A small minority of individuals cannot clear an infection with human papillomavirus, which eventually over time can lead to abnormal cells on the cervix, and eventually that will develop into cancer. We've got new technology for the last few years in the form of human papillomavirus vaccines that can prevent infection with the most important cancer-causing types of human papillomavirus. We've been interested in human papillomavirus as a research topic for the last few years. One of our large projects in collaboration with researchers from the University of Pretoria was to do a large demonstration project in schools around Tygerberg on the Cape Flats, where we tested whether an introduction of HPV vaccines in a particular age group would actually work. So we approached schools, we combined the vaccine program with screening through normal pap smear technology of the parents of the children being vaccinated, and we had excellent response from the population. So this combination of primary prevention through vaccines and secondary prevention with pap smear screening or HPV testing was tested even before the minister announced the national program for HPV vaccines. Another important research area that we focus on is the association between HIV infection, human immune deficiency virus, and human papillomavirus, and how these two viruses work synergistically in sort of helping each other to cause disease. We've looked at the association between HIV infection and cervical cancer precursors on cytology, and how antiretroviral therapy has an effect on HPV disease. Also, more recently, we've realized that there's probably a doubling in risk for HIV acquisition if somebody is infected with human papillomavirus infection. This is quite new, exciting findings, which leads one to think that perhaps by giving HPV vaccines, we can reduce the burden of HIV transmission. We've started testing this hypothesis in a large study where we work together with the Moffitt Cancer Center in the United States, where we look at young people at high risk for contracting HIV, and then seeing whether HPV vaccines might partially protect them against HIV acquisition.
So our study is related to the cost of treatment of childhood cancer in Africa. And this is the first study which looks at the cost of treatment of the most common cancers of the children in Africa, and we try to answer the question, is it really affordable and cost effective to treat children with cancer in Africa? Obviously, we all know African continent is a young continent and almost half of the population is represented by children. Childhood cancer is not even listed among the top 20 causes of death. However, every year, more than 50 to 60,000 children will suffer from cancer. Survival rates here remain low, mainly due to the lack of affordability and high rates of abandonment. So we don't have any information regarding the costs, which actually makes it impossible for policymakers to adopt affordable intervention. So we decided to start a study, and the aim of this study was to estimate the health system costs of cancer care in Africa, and in this way to propose a more effective approach to investigations and treatment for the most common cancers. So we did choose the top 4 cancers in children in Africa, and we decided to look at the costs which involve direct costs and indirect costs. The cost of the disease ranged between 9,000 rand to 48,000 rand, and obviously the more expensive was the more advanced type of cancer. The earlier the diagnosis, the better the prognosis, and obviously the higher the survival rate of those children. So in this context, not only that those children will have a fantastic chance and an excellent prognosis of survival close to 90%, but the cost of treating those patients will pay benefits to the society in the long run. Treating childhood cancer in Africa is definitely cost effective, and key policy points from our research are the need, 1, for recognition of childhood cancer as a health problem by the African governments, 2, improving awareness and early diagnosis, 3, adapted protocol, which are absolutely essential for the local resource-limited conditions, and of course that the treatment is affordable, and in this way we can save many children on the African continent.
So the topic I was talking about today was understanding the brain, doing it with dopamine. So I've seen the evolution over years of our understanding of how the brain works and the huge contributions that have been made in terms of the brain imaging advances and particularly our understanding of genetics and the contributions of very complex genetics factors and epigenetic factors to brain function and brain dysfunction. So some recent studies have identified multiple genetic risk factors for diseases such as schizophrenia, and we now understand that these factors interact with various environmental factors such as childhood trauma, such as substance abuse, and that in susceptible individuals complex disorders such as schizophrenia can occur. And understanding the neurobiology and the neurochemistry is critical to providing effective treatments and interventions for these disorders. And one of the areas that we've focused on is the dopaminergic system, and in particular the mesolimbic and frontocortical dopaminergic systems, which are very important in reward mechanisms. So, for example, in substance abuse, addiction disorders, we find that patients have dysregulated dopaminergic systems here, and that when we intervene to try and treat individuals with these disorders, we really have to understand more about the neurobiology and how we can correct this if we are hoping for a better outcome. So these are areas of really exciting development in the field of neuroscience, specifically neuroimaging and genetics is where the major advances are being made these days, so that we're putting ourselves into a position where we have a much better conceptual understanding of brain function and brain dysfunction, and that we're in the process of developing much more sophisticated interventions targeting specific systems with the hope of improved outcomes.
My research concerns biomarkers for TB treatment outcome, and this stems from the rather complicated treatment regimens that we currently have for TB. It takes 6 months to treat somebody with tuberculosis, with drug-sensitive tuberculosis. And the problem is that it takes a very long time before we get the first indication of whether somebody is responding to treatment or not. In fact, the first indicator for treatment effect is after 2 months, when we look at sputum culture for the bacterium, and if the bacterium that was initially there is no longer culturable after 2 months, then we say, well, this patient is responding to treatment, and then we carry on for another 4 months of treatment, and the final indicator of treatment success is then after 5 or 6 months. And that's of course a very long time for an individual to know whether they are responding, and for the medical team to know whether their patient is responding. The overall problem is then, how do we test a new treatment regimen, a new drug in a new treatment regimen, if we really have to wait 2 months before we get the first indicator of treatment success, 6 months to get an interim indicator of success, and up to 1 year after completion of a 6-month regimen to get the ultimate treatment efficacy evaluated for that particular new drug or regimen. So what we are trying to do is to speed up this whole process, to find markers that tell us very soon after the start of treatment whether somebody is responding to a new therapy or not. And the way we do that is we look at hosts' immune responses. So we look at the body's reaction to the infection and to the drug, and whether there are changes in the inflammatory markers in the blood that tell us, well, this drug is actually working, this patient is responding. And we've done that in collaboration with a lot of researchers in this faculty and also overseas. We've looked at patients that relapse or don't relapse, and we have measured a range of analytes in their blood. And in this research we are showing preliminary data that indicate that very early, within the first 4 weeks, we can probably say whether a patient is going to fail treatment and whether the patient is going to relapse. In the other part of our research, we have employed a fancy new imaging technique called PET-CT scanning, positron emission tomography, which is really measuring isotope uptake in the lungs of people with various conditions. It's often used in oncology to look for metastases. In this case, we're looking at isotope uptake. It's a isotope labeled glucose that we administer to patients, and the nuclear medicine department does this PET scanning, and it's combined with conventional CT scanning, so you get an indication of the anatomical features of the lung, plus then this functional assessment of isotope uptake, glucose uptake, which indicates inflammation. And we have used this tool to evaluate disease burden in patients, so more uptake means more disease, and we follow that during treatment, and we see that at the end of treatment a large percentage, about a third of patients, still have ongoing inflammation in their lung with standard TB treatment. Although they appear cured, they still have inflammation in their lung which can last up to a year after the end of treatment.